안녕하세요. 김용진 원장입니다.
Hello, this is Kim Yong-jin. After even successful implant surgery, in the early stage, you end up experiencing various post-operative early complications. There could be infection or due to secondary bleeding, severe swelling or post-op pain or resulting hematoma could be things that you could experience. Or also rarely there could be wound dehiscence or nerve damage. At this lecture, I'm going to talk about post-operative early complications. So first, after operation, if there is pain and swelling, what to do about it is what I'm going to cover. And then we're going to look at early infection and nerve damage and wound dehiscence. And last but not least, if there is thermal damage. So first, after operation, if there is pain and swelling, sometimes after 3 days post-op, there could be severe swelling like this, and some patients also experience pain. If it's plateless surgery, like one guide, this the risk goes down. But if you had to do GBR or sinus surgery, then post-op swelling or ecchymosis could happen quite frequently. So for the reason for such swelling ecchymosis are simple. There could be severe tissue damage due to prolonged surgery time, or there were bleeding during surgery, or bone bleeding became severe after surgery, or there was traumatic surgery. So as swelling goes down, mostly you see this type of ecchymosis. So this type of ecchymosis, the bleeding that happened inside is absorbed by skin. So the results in the beginning, the skin turning purple, and then it becomes yellow. In most cases, it seeps out through the lymphatic drain. So in the submandibular lymph node and during the jugular chain, under the neck, above chest, it goes down. So you had surgery on the maxilla posterior, but you see that this happens in the neck and above chest, and if you wonder why, this is the reason. And similarly, sinus supposed side, and you had upper jaw surgery, but with the swelling goes down. The bruise happens actually at the bottom side. So submandibular lymph node and jugular chain is where it's drained. And if you remember that, it will be easier in terms of patient management. So due to severe bone bleeding, there could be swelling ecchymosis, but it goes away naturally, and there's no special treatment for that. After 2 to 3 weeks, the skin turns yellow and it disappears. If you want to remove it quickly, using hot pack could be an option. Like this on the upper side, you did flap retraction and rib split for 4 implants. So there could have been severe bone bleeding. So for this patient, it ended up as a swelling post-op, and as swelling went down, the bleeding inside is resorbed by skin, end up with the ecchymosis at post-op 1 week. And when there's ecchymosis, the swelling goes down. So even for severe swelling, you have to be mindful that there could be ecchymosis as swelling goes down. After 2 weeks, the colors disappears and it turns to normal condition. So again, there is not much treatment for this, and it's inevitable if you have a lot of bone bleeding during surgery. So to prevent that, of course, it would be better to have atraumatic surgery and to minimize bone bleeding. As I said in the last lecture, if you have bone bleeding, then proactively, before closing the flap, you have to control bleeding. That would be the best way. So things you could do is a post-op, you have to quickly control bleed during the surgery. You have to exert effort to control bleeding in the surgical site, and after surgery, through the pressured dressing, you have to stop bleeding. So in case of cold pack, I recommend using for 24 hours after post-op, and after that I don't do anything. But if the post-op swelling is really severe, or if there's ecchymosis, then I recommend using hot pack. So for me, for after 1 week post-op, I recommend using hot pack from that point on. So within bone, if there's a wide area of surgery, and on the area crest, not only just biting the gauze in that area, in the area where the bleeding can really happen severely, you have to pressure that area. If you had a lateral approach for the sinus surgery, on the top of lateral window, you put a thick gauze, and then on the alveolar ridge crest, you put gauze and ask the patient to bite hard. And through that, through the buccinated muscle, the vestibule gauze will be pressured. Then post-op, as anesthesia wears off, secondary bleeding can be prevented. And in case severe bleeding is anticipated, like this, pressure dressings using skin tape and gauze, you could put pressure on the surgical site, and I put that on till the next morning of the surgery, and this will be a good way to prevent swelling and bleeding. Next, let's look at early infection. Now, depending on patient condition or during surgery, you have not had the aseptic procedure, or the primary closure failed, and there could be secondary infection. So after post-op, immediately there could be, because of these reasons, infection if you have swelling and pain. So in post-op conditions, pain and swelling versus coming from infections are different. So how can you distinguish between the two? Swelling and pain after plus 1 day from surgery is very normal post-op surgery. But if the pain and swelling went down, and after 5 to 7 days, if you have secondary swelling and pain starts again, and in the surgical site there's redness, or patient's skin showed some redness, then you have to think about possibility of infection. In summary, immediately after surgery, just because there is a pain and swelling, it does not mean there is infection. After 5 to 7 days of infection, if you see redness and pain and swelling again, then you could consider a possibility of early infection. The management you can do in different ways. I recommend step-by-step approach. What I usually do is first I use medication. And use antibiotics, in other words, amoxicillin or antipeninsula-based augment or cepa could be things that you could use. So you use preventive empirical antibiotics for about 1 week or so. So post-op, to prevent infection, you prescribe antibiotics, and for post-op early infection, it happens again 5 to 7 days later of the surgery. So if you prescribe antibiotics at that time again, it goes down. Of course, you have to regularly follow up the patients, but sometimes it doesn't really have a successful result. Sometimes you have swelling in local site, or there is a fluctuation in the swelled site. The area is soft to the touch. Then it means pus has been formed. So to remove pus, you have to use incision and damage or drainage in other words, IND. So after lateral approach sinus operation, after 4 weeks, face swelled up, and the patient also complained about heat. So I could see fluctuation there, and because there was swelling, also pain, so I diagnosed it as a post-op early infection. The fluctuation means it's filled with pus inside. So I did IND, the incision and drainage. I opened with a blade and I could see pus seeping out immediately. So you see the pus being drained. So here you have to use some drainage so that the pus can continue to seep out. So because of infection, pus resulted means there is anaerobic bacteria a lot inside. So you have to switch to aerobic conditions and you have to drain the pus out. You could use elastic drain, or if you don't have drain at your clinic, you could also use gauze. So in this case, like this, I opened it up and using mosquitoes or peristernal elevator, I did blunt dissection. So I went a bit deeper into the infected area, and then put a gauze inside, and to fix in the place, I sutured it up. So until the symptom disappears, you have to maintain it for 3 to 4 days, and then drain the area every day. Then the symptoms will subside, and then you remove it, and after removal you don't have to do any additional suturing. After that, symptoms improved, everything turned okay, and the implant that I placed and graft material that I used all could be saved. Final prosthesis were successfully delivered, and there was no additional infection. So still, sometimes it doesn't get you results. Then what to do? If in such case, the implant that you have placed or the graft material or membrane all needs to be fully removed. So if you also have placed implant, and even removing implant could be an option. So you do IND and did IND even after using medication, did not get any result, and on the x-ray the patient still complain about infection and have those symptoms, then immediately remove everything that could have potential for infection. We call that debridement. So you remove everything, wait, and the soft tissue has been healed, then you do second surgery. That would be the best way. Next, let's look at nerve damage. In case of nerve damage, actually it happens during operation, but you only detect it after operation once the anesthesia wears off while the patient is in the recovery. So it's, I think, right to classify it as an early compression post-op. Many cases, even there's nerve damage during surgery, you cannot be able to detect. So most often, inferior alveolar nerve is injured during the surgery, and it could be, depending on the level of nerve damage, there could be 3 types. First is neuropraxia. So it's not direct injury to nerve, but it's indirect injury, like compression injuring. So it's an indirect damage. So like the sheet or inside the nerve, there's not much of damage, but due to compression, the nerve transmission is blocked. In most cases, it's completely recovered. So if you have neuropraxia, then you just have to follow up the patient and check that there's a full recovery. Next is axonotomosis. So the axon area is partially damaged. And in such case, again, while drilling the area could have been partially damaged, or while placing the implant, mandibular canal was broken and implant ends up touching the nerve, thus resulting in exonotomosis. Next is neurotomosis, and it's direct damage to the neuron or nerve. So sometimes it fully breaks, or there is a partial breakage. So X-rays only with that, whether the nerve has fully broken or partially, there's a tear, or only axon has been damaged, we cannot know. So you just follow up the symptoms, to follow up checks and see whether there is a recovery or not. So if there's a neurotomosis, it's better to ask the oral surgeon to do angiostomy or do prescribe medications. So it's better to do that at early stage. So due to bad drilling, the nerve could damage, and sometimes nerve will break, and thus resulting in this. So if there's a nerve damage, patient complaining anesthesia is not wearing off, the most important thing is how to evaluate it. So first, the most important thing is the area, the mapping where there's a dull of sensation needs to be done, and patient subjective feeling. So from like 1 to 100, what is the damage level needs to be recorded, and every time the patient comes in needs to be checked whether it's improved, the same, or it's getting worsen. So you have to check the progression. Also, you need to map how far there is no sensation and whether that area is getting smaller or not. So there could be different treatment options for neuropraxia. Mostly heals with time. But most cases, as the nerve recovers, there's itching or burning or warm creeping sensations, or there's like glittery going through. If the patient says that, this is a very positive sign indicating recovery. However, if you want to hasten the recovery, the following approach can be used. Now, surgical surgery you cannot do to outpatient. You need specialist intervention, so you need referral. So if you think for sure there is a neurotomosis, you have to refer to the surgeon. So if the anesthesia wearing off is not fully there, so if there is some dull sensation, then first you prescribe steroids. I often use 5 milligrams of prednisolone, and I taper with this regimen. First day 6 tablets, second day 5 tablets, and then 3 to 4, then 3 to 1 on the following days. So post-op, in total 6 days, 21 tablets of the prednisolone 5 milligram is prescribed. So 6, 5, 4 to 3 to 1 is how it's tapered, and after 1 week I check the nerve damage level. And I don't usually use this more than a week. If there is a dull sensation or lack of sensation, then you use steroids, but sometimes you use gabapentin. If there's a nerve damage and there's nerve pain, then I use gabapentin. So gabapentin regimen is as follows. But what you need to note is if you have to use this type of medication, it's better to refer to the oral surgeon. Gabapentin in the first week, 3 times a day, 100 milligrams, and from the week 2, 200 milligrams, and then you do checkup, and the third and fourth week 300 milligrams. So max you can increase up to 600 milligrams 3 times a day. And of course, follow-up regular checkup is a must. You have to check whether pain has gone down. So this is also mostly used for prosopalgia. And if you have a soft laser, you could also use laser treatment, and using hot pack or the infrared treatment sometimes can be helpful. But the most important is prevention. From the mandibular canal to metaforma anterior border, you have to have sufficient safety margin so that nerve will be protected. And on the if the residual bone in the lower posterior area is there is only very little, then it's better to use cast drill. If you have a tapered or twist drill, there is a wide dimension tip, and this wide dimension tip is not really marked in the length of the drill. So if you drill up to laser marked area, from there the Y dimension is 0.8 to 1 millimeter more. So you drill 1 millimeter more. So what happens is this. The nerve would not perfectly tore, but the axon damage or compression damage or neurofracture could be the result. So if you use twist drill, then sharp drill could directly damage the nerve. But if you use this type of cast drill, as cast drill has a rounded tip, which means it cannot touch the nerve directly because cortical bone knit will be formed, meaning you can have more safe drill. Another thing, you can attach a stopper, so drilling depth can be exactly controlled. So 6 to 7 millimeter implant is being placed, then you could use cast drill. And recently, Ostom has come out with 485 kit. So if you place from 4 to 8.5 millimeter implant, the safe drill to use. So 485 drill could be something I could recommend and good to use. Another thing is wound opening up, wound dehiscence. So it's due to primary closure resulting in failure. So the important thing in the suture principle, if you don't have reversion margin, wound would open up. So in case of simple implant placement, it might be okay. But if you do also GBR or sinus surgery also, in other words, graft material has been put in, if the wound and result in wound dehiscence, there could be infection. So why is eversion the most important in the suturing principle? This is because in the healing, wound healing, there's a contraction and contract on the central direction. So after suturing, the margin is equal margin. What would happen? It would open up with the contraction. So to create eversion, what is important is that buccal pleb and lingual pleb, you have to go one by one. In other words, needle, when it goes through, penetrate, you go one by one. And what's more important, the base of the flap needs to be wide. So as you can see on the top, in the triangle, so if the flap base is shallow bite, then it will be inverted suture. But if the flap base is wide in bite, then it can be everted suture. So you have to remember that principle. Hence, as I said before, the flap base needs to be wide, and one by one, you need to penetrate. And if the flap you think would have a lot of high tension, the matrix suture would be recommended. So, always, after suturing, if you have to have a good primary closure, then like Himalayas, mountains, everting, the buccal lingual plate needs to be pulled as much as possible to create the everting margin. Last but not least is thermal damage. We could also call it compression damage or heating necrosis. In most cases, in D1 bone, while drilling, the heat could cause damage, or in placing implant, sometimes the high torque could result in damage. Most of the cause is bone heating or bone damage. Most of the symptoms is on the apical side as a region radiolucent region can be seen and it protrudes. So symptoms could be chronic dull pain, continues even after 1 or 2 weeks after surgery. On the PA side, you have radiolucent region that you could see, and that could be the thermal damage. So prevention is the best option. So as I said, in the one-guide related complication, prevention is the most important. So in D1 bond, the tapered 1 to 2 taper kit recommended drilling protocol needs to be fully complied. In most cases, if you use high placement torque, this could be the result. If the bone quality is good, then you use pumping motion for drilling and use the cold saline. And if the drill is blunt, best to drill beyond D1 bond with the new and sharp drill. So in this lecture, I talked about various post-operative early complications. So when you do implant surgery, even if you think the surgery went well, depending on the patient's factors or depending on your surgery skills, sometimes such complications can be inevitable. So if you can avoid these complications, then you'll be good, but sometimes it's inevitable. So if you have such complications, you need to understand how you need to respond and do treatment, then you can prevent from the situation getting worse. Thank you for your attention.